Hello and welcome to this VJHemOnc podcast. This episode is part of the non-malignant channel on VJHemOnc, which is supported with funding from Agios. The supporter has no influence over the production of the content. This podcast is intended for healthcare professionals only. In this episode, we explore the latest advances in gene-based therapies for sickle cell disease and thalassemia, with gene editing and gene addition approaches now moving from clinical trials into real-world practice. These therapies are beginning to transform outcomes for patients with inherited blood disorders, shifting the goal from disease management to potential cure. We will hear from leading experts on how these advances are shaping patient selection, treatment delivery, and clinical outcomes. So, let's begin. As these therapies become available, one of the key challenges is ensuring timely and equitable access for patients. Sunil Gupta discusses the need to expand access to gene therapy for patients with sickle cell disease, particularly given the significant disease burden and impact on quality of life.
Sickle cell is something which unfortunately lagged behind again. We had lovely 3 drugs, or 2 approved drugs, so to say. The third drug was not approved in the UK. 2 drugs which were approved but then withdrawn, unfortunately. And at the moment, of course, we have got the gene therapy. The gene therapy is very expensive, and it is again happening in very concentrated centers, which I totally agree and fine with that. But I think what we might need to do, that we need to make it more accessible, and we need to fast track these patients. I have got so many patients in our center who are suffering in a big way from sickle cell anemia, and gene therapy should be made accessible to these patients much quicker. And we might have relaxed the qualifying criteria for these patients, because as you can imagine, that these patients' quality of life is quite poor, and of course their organ damage will happen more and more as they actually wait longer for the gene therapy. So that is my anticipation and expectation again in this area. We are making fantastic progress in other rare diseases like hemophilia and thalassemias, but sickle cell anemia, we are the second largest center in the country, and gene therapy needs to come thick and fast to these patients so that they can be benefited with the new advance in science. This is the most happening time for hematology last 10 years, and we have seen massive progress, and that is good for science, that is good for patients.
While significant progress has been rapid, translating these advances into routine care will require improvements in access, infrastructure, and patient pathways. Alongside access, determining which patients should receive gene therapy remains a complex and evolving area. Alexander Ngwube discusses how clinical trial eligibility criteria may not fully reflect real-world patient populations, highlighting the need for a more individualized approach.
Before now, there was a study criteria for patients. So the study criteria is that you had to have had vaso-occlusive events, about 4 of them in a 24-month period. And they were very specific. You can't have had strokes. You couldn't have had moya. They were excluded from the trial. Now, the problem is that has translated, but that's not real life. We have patients that have a pain crisis. And we know that the older these patients get, the worse they become. So you have a 12-year-old who's qualified to go on study who has had one pain crisis in 1 year period, and you're asking me to deny them that when I know that by the time they turn 16, they may have had multiple organ affectations versus what the study is saying. And so there is no clear guideline. And I think, in my personal opinion, I think this has to be personalized individual by individual. But like I said, right now, I think and I think we'll talk about that later on, but the most important thing is that we have the criteria, but I don't necessarily think that works for everybody that is coming on for gene therapy. And I think it's a very difficult one because the resources are limited. If we have unlimited resources, I think it's easy for me to say it should be individualized based shared decision making. But at the same time, we know that resource is not available for everybody. And so I think there should be a picture of the two. There should be a mirroring of the two. I'll give you a perfect example. I have a 15-year-old that has never had a pain crisis before in his life. And he comes to me and says, I want to get gene therapy. And at the same time, I have this 19-year-old that has had multiple pain crises. And I know my resources are limited. I think I'll be offering it to the 19-year-old compared to that 15-year-old. But that doesn't necessarily mean that I'm saying no to the 15-year-old. I'm just saying maybe not now. But what makes that right and what makes that wrong is a little bit tough. So what I'm trying to make is that I do not believe in the strict timeline, the strict eligibility criteria. But at the same time, as much as I believe it should be a shared decision making, but I have to have at the back of my mind, what are the resources available for such institutions? If they have the resources to offer it to everybody, go for it. But if they don't necessarily have that, I think there should be some thought behind every decision that has been made and who is being offered gene therapy.
These decisions often involve balancing disease severity, patient age, and available resources, reinforcing the importance of shared decision-making in clinical practice. Patient selection also differs between disease types, with distinct clinical considerations in sickle cell disease and thalassemia. Rabi Hanna outlines key factors influencing patient selection, including organ function, iron overload, psychosocial assessment, and the practical challenges of stem cell collection.
I'm going to break it in two for thalassemia and for sickle cell. For thalassemia, it's so important. It's first, depending on your centers and the region. So in the USA, you can have access to two medication. One, it is beta cell that is approved for age 4 and higher. So age is the first factor. The other medication, XSL, it is age 12 and higher. Versus in the rest of the world, in Europe and in the Asia, it is only XSL that is approved. So that will be first factor within the thalassemia. Second, it is really the liver function. That it is the most important factor, that it is predicting both from iron overload impact on the liver and also on the heart. So pay attention to both of them. And there is discrepancy. Not always, like you sometimes see the liver iron, it is acceptable, but the heart may be actually more overload. So you have to really evaluate this too carefully, because this is somewhat elective. Take your time in optimizing the iron overload status. Put this patient on 2 iron chelation, be more intense so you could decrease their risk, and even do more functional assay like or testing like FibroScan, or if needed, liver biopsy to ensure that the liver is okay and not adding any risk. For sickle cell, what I would say, it's the psychosocial and the pain assessment. You really need to work collaboratively with the hematology, who they know this patient a little bit better. That collaboration enables you to provide more holistic care for this patient, both in preparation and counseling them, but also prospectively after that, how they can go back. And second, it is the stem cell collection. You need to work with your apheresis team. This is the critical piece we learned from it. Apheresis, they do 100, if not 1,000 of collection for adult patients with multiple myeloma or lymphoma for CAR-T. The collection is simply just different. So there are some practical notes. I mentioned how they have to go deep in the well to collect because the stem cells tend to be a little bit lower. Number 2, you need to get more blood volume, around 4 times. And even the inlet flow, you need to slow it, the anticoagulation. So you have to work with the apheresis team and re-audit, do continuous improvement for your own product when you collect, and see how can you improve on that, and share and learn from other centers who may have collected a little bit more specifically in sickle cell patients.
Together, these considerations highlight the importance of a multidisciplinary and highly individualized approach to care. Beyond selection, delivering gene therapy involves multiple complex steps, each with its own challenges. Dr. Hanna also shares insights from real-world experience on optimizing the gene therapy pathway, from patient selection and stem cell mobilization to conditioning and long-term follow-up.
This is a really exciting time in the area where we provide transformative care for patients with sickle cell and thalassemia. But now going beyond just the clinical trial to real-world evidence, I wanted to share the lessons we learned at Cleveland Clinic with the rest of the community where they are starting a new program for gene therapy. So in my talk, I provided lessons from different aspects and phases of therapy. First, it is selection. I think this is really important to be able to partner with the classical hematology team. They're hematologists who provided care for this patient for many years or decades. Their social work, their RN. So what we learned at Cleveland Clinic, we did a monthly committee, not only a BMT physician, but also the hematology team, so we can discuss the patients, select them based on their morbidities, but also their psychosocial. And that was really helpful for us to sign in and also sign out because we want this patient to go back to their primary team. Number two, within the selection, it is a chronic pain. It is many of the adult patients with sickle cell specifically, they suffer from chronic pain. And we initially were restrictive and we were not allowing patients to have more than 10 pain admission per year. But then we felt patients who may have a vascular necrosis, why we are not trying to treat them. So we added a layer of psychosocial assessment to enable us to really detect if any patient has any mental health disorder that could contribute to the chronic pain and help us select patients who could benefit from this. In the second phase, which is the stem cell mobilization and collection, this is critical. We learned, because I think in real world, we don't have the optimum patients that they may be in real world. So instead of the average being or the mean 2 cycles, we are seeing actually 3 cycles or more as the mean number of cycles for stem cell collection. So critical is to set up the expectation for patients that they may take up to 6 cycles. And also maybe we don't collect enough for this patient. So counseling them appropriately. And I call this is the GVHD of gene therapy because it's the uncertain. It is the unknown part of how long it will take. We know, we have learned and shared data to show age is a good prognostic. If you are younger than 18, you usually 1 or 2 cycles is enough. But older than that, they can really have challenges in that. Within this phase also, it's so important to optimize mobilization. So currently in sickle cell, plerixafor has been the agent that we use, but there is exciting data was shared from the Kingdom of Saudi Arabia, where they have done GCSF plus plerixafor. I do want to provide word of caution. This really need to be careful because GCSF is associated with mortality and morbidity, so it has to be done carefully and in a very well-established setting. But we shared our data with using a newer agent called motixafortide in 15 patients. And this is exciting because it is similar to plerixafor, but seems to be more potent and more data to come because we provide data about collection. We need to see how this will perform during infusion. The third phase, which is the chemotherapy, we shared our real-world data from using busulfan and how we switch from once a day dosing to Q6 to decrease the risk of veno-occlusive disease, how to manage the neutropenia that it seems to be late, but it's prolonged. But also exciting, there is a newer gene therapy like the one that used base editing, as in the study with Beam, that shortened the duration of neutropenia significantly. So it's more exciting, and I want people to look forward to the future. And finally, it was about the fertility and some of the long-term data. It is so important to be able to gather information about the long-term data for this patient, not only from a pain crisis, but how's their end organ function? Lung, kidney, liver. So we established, in collaboration with many other centers, the Regent Consortium, where we are collecting information from our patient that can help us guide for the future. If a patient has vasculopathy, pulmonary hypertension, how do they do? So that's really exciting time now, and I hope we see more centers collaborating with us in this consortium.
As these programs expand, insights from early clinical experience will be critical in refining process and improving outcomes across centres. A key challenge in delivering gene therapy is successful stem cell collection, particularly in patients with sickle cell disease. Zachary Crees discusses emerging approaches to improve mobilization, including the use of novel agents such as motixafortide, with or without additional targeted strategies.
The study that we conducted in sickle cell patients to improve mobilization involved the use of motixafortide as a single agent alone, and then subsequently in the same patients, a second mobilization with motixafortide plus natalizumab, which is a VLA4 inhibitor, looking to see if we could improve the ability to collect stem cells for sickle cell patients going on to gene therapy, which is a significant unmet need in the field right now. We have FDA-approved products, and a significant proportion of patients can't collect any stem cells to be able to receive those curative therapies. And so what we observed in this study was that motixafortide alone and in combination with VLA4 inhibitors improved significantly our ability to mobilize hematopoietic stem cells. And those levels that we were able to mobilize corresponded with a predicted ability to collect enough stem cells for a gene therapy within just one collection cycle, which is significantly better than what we would have predicted or what we was observed in the pivotal trials using single-agent plerixafor, which is currently the standard of care. And importantly, that we were able to use those mobilizing regimens that improve mobilization without any significant increased risk of toxicities.
These strategies may help increase the proportion of patients able to proceed to gene therapy, addressing a major limitation in current clinical practice. Encouragingly, clinical data continue to demonstrate the transformative potential of gene-based therapies. Rabi Hanna discusses updated results from the Ruby trial of gene editing therapy in severe sickle cell disease.
The Ruby study, which uses Reni-cel, which is a gene editing for patients with severe sickle cell disease. The study today will update about the result of 40 patients who were enrolled aged 12 to 50, and we now have really a more prolonged follow-up with the median of follow-up close to 13.6. And the main message that it is really showing consistently same safety profile that it is we expect with the busulfan myeloablative, but importantly, it's really fantastic efficacy. 38 out of the 40 patients are pain-free as of the last cutoff of the data. So this has showed us continued improvement for this patient. And importantly, in today, we are also reporting the pain scale and also the physical activity. Both measurement of patient-reported outcome are seeing continued improvement and normalization almost of what it is reported by patient. So it's not only that they are pain-free, but also their physical stamina, their pain score is back to what's expected for normal population.
As highlighted, these therapies are associated with high rates of freedom from pain crises, alongside meaningful improvements in physical function and patient-reported outcomes. Overall, gene-based therapies are rapidly transforming the treatment landscape for sickle cell disease and thalassemia. From improving access and refining patient selection to overcoming practical barriers and delivering durable responses, these advances are bringing the field closer to potentially curative approaches. Thank you for listening. To explore more expert insights and interviews, visit VJHemOnc.com. Follow us on X at VJHemOnc to join the conversation, and subscribe to our podcast on Apple, Podbean or Spotify. Until next time.